It's Friday, the 9th of May, and this is the Hot Topics podcast. Welcome to the Hot Topics podcast from NB Medical. My name is Neal Tucker, and as usual, I'll be taking you through the next 20 minutes or so on the latest research that's interesting and relevant to us in general practice. Before we start, a bit of NB news. So firstly, since the pandemic, we had become predominantly a company of online courses. I know I've met many of you out and about when we've done our commissioned courses around the country, and it's been absolutely fantastic. It's always great to meet people in person, to be in a room. It's a very different experience. Especially from our perspective, it's much more fun. I hope it is for you as well. So I'm really pleased to say that we're about to start to reintroduce our traditional face-to-face courses. Check out the website for more details, but we will be doing 2 dates in September, the 26th and the 27th. That's a Friday and a Saturday. They're going to be in London, and I really hope that this goes well. We'll be doing our main Hot Topics course, and fingers crossed that this can be start of us doing more of these around the rest of the country too. Meanwhile, of course, our online offerings continue to grow. So over the next few weeks, we've got our regular Hot Topics GP update course coming up. We've got Hot Topics in Cancer for Primary Care, our men's health course as well. And then at the start of June, our brand new lifestyle medicine course. Check out the website for all the details. And of course, if you haven't come across MB Plus before, do check it out. For just under £30 a month, you can come on all of our online courses that we do live and on demand, and access a whole host of other things on the website too. Lastly, if you're a GP trainee or if you're maybe a trainer, then it's worth knowing about our new AKT question bank. So we've got a new AKT exam question bank designed specifically for GP trainees preparing for their AKT exam. You can test yourself for free, and then we've got more than 900 practice questions covering the whole of the curriculum to help make passing your AKT a breeze. So please do tell your trainees about this. Okay, so this podcast, we've got 3 papers to look at. One in the BMJ on a GP intervention for PTSD in ICU survivors. Yeah, I know it sounds a little bit niche, but bear with me. We'll chat a bit more about that. We've got a paper in the Lancet looking at whether GLP1 receptor agonists can help walking distance in patients with intermittent claudication. And then thirdly, we've got a paper in the BJGP looking at physical activity interventions in general practice for cancer survivors with troubling symptoms. Yeah, it feels like we're running the whole gauntlet of general practice in just 20 minutes. Okay, first up, we've got this paper in the BMJ, and this caught my eye because I've just finished reading a book called Poor by an author called Katrina O'Sullivan. It actually came out a couple of years ago, so you may have come across this, and I'm just a bit late to the party, but it was entirely new to me. And I have to say, it's one of those books that completely reframes how I think about the world, and I don't say that lightly. So it's about a lady who grew up in poverty, surrounded by addiction. It's an autobiographical account of her childhood, her adolescence, and then moving into adulthood, and how these events have shaped her life. And the reason it had such an impact on me is that it's just a really good window into a world that I assumed I knew, that I could understand, but in fact I had absolutely no idea about the circumstances in which some people were living, and how that shapes their actions, their life choices, and how even though we may perceive that people always have a choice to go to school or not to go to school, a choice to keep going with your job or not going with your job, a choice about the partners you may have in life or not, a choice about whether you engage with health interventions or you don't. Well, actually, this book shows that frequently this isn't the case. I would go so far as to say that I think that this book should be essential reading for everyone that's going into medicine or who is in medicine. What the book demonstrates, and I really encourage you to read it, I'll put a link to it in the podcast description, but what it demonstrates is, particularly if you live in poverty, or particularly if you come from a family where you're often surrounded by chaos, as is the way with many people that grow up in families particularly affected by addiction, then there is a really high chance that you are going to be exposed to some really nasty adverse life events, and you're going to suffer trauma. And that trauma can take many forms, but when people are affected by trauma, that can have lifelong effects on them. And it made me realize that in my day-to-day practice, I don't consider the risk of trauma enough, and I don't ask about it enough. And perhaps if I did, that might explain some of the issues that people present with regarding mental health problems, for example. It perhaps also explains some of the chaotic behavior that we see in this group. We may perceive that as just being a bad attitude. And I think it's really easy to write these patients off, to say that we can't really help them. But actually, often it may just be that we can't understand the situations that they've been living in and how that then shapes their actions. So yeah, I would highly recommend reading this book. So Poor by Katrina O'Sullivan. And I'd be really interested in hearing from you and how you feel about the book, whether it's changed your thinking at all. So if you go on and read it, or if you've already read it, then please do get in touch. So you can email on hottopics@nbmedical.com. I'd love to know your thoughts. Enough of the book reviews and back onto the research. And I appreciate that it may feel like the link between what I've just been talking about and this paper is a little bit tenuous, but the central theme of this research is about people who have experienced trauma and looking at the effect of a novel, brief, GP-led narrative exposure intervention to help with PTSD symptoms after intensive care. Just to give you some of the figures from the paper, 1 year on from an ICU discharge, 1 in 5 patients will have post-traumatic stress disorder due to their serious illness and hospital admission. I don't know how many of our patients in our day-to-day practices will have an ICU admission. It doesn't feel like it's going to be that frequent as a single GP. But I guess if you're in a practice for a long time, you've got your individual list of patients, it's going to happen at some point, possibly over the years more frequently than we might imagine. I have to say, I've never really thought about exploring the mental health side of things after one of these ICU admissions, at least not proactively. I hope that we still live in a general practice world where if we did have a patient who's had a horrible illness and a really complex hospital admission and is eventually discharged, that we'd maybe be able to still pick up the phone and check in with them about how they're doing and asking them about their mental health and perhaps specifically about PTSD would be something really valuable. This was a randomized controlled study conducted in primary care in Germany across 319 practices. And I have to say, when I first saw the paper, I did have some reservations about it because the intervention that they're using is quite labour intensive from a practice perspective. So GPs would deliver 3 consultations using this psychological technique that's been proven to improve symptoms and mental health in people with PTSD. Each of those consultations would be 45 minutes long. And of course, you and I realistically wouldn't be skilled in delivering that type of intervention. So you need training as well, which is going to take another 60 to 90 minutes too. It's not just GPs that's getting involved. There's also nurse follow-ups. In the study, in fact, they had 8 nurse follow-up phone call appointments. But they are much shorter and they weren't delivering a therapeutic intervention. They were monitoring those patients for any enduring symptoms. And if things were getting worse, they would flag that up to the GP, who could then do additional consultations as appropriate. It's just worth touching on what the actual intervention is, because probably most of us don't have much idea about how you can treat PTSD. It feels like a condition which really would be the remit of a specialist, of a psychologist or a psychiatrist with specific knowledge and training in this area. Interventions that I've come across before include things like trauma-focused CBT, also EMDR, which is eye movement desensitization reprocessing. That's got some good evidence to support it. But this is a different style of intervention called narrative exposure therapy. It's a trauma-focused intervention, and I'm quoting directly from the paper here now, that uses storytelling to reconsolidate, answers on a postcard, the autobiographical memory by constructing an illness narrative for patients who have been in an ICU. And then that helps to integrate fragmentary memories into their own life history and realize what happened during the ICU stay. And I guess it helps them figure out a bit about what's been going on and then makes them re-experience the trauma, and through that allows them to process it, hopefully then improving the underlying condition. They managed to recruit 319 participants who had had an intensive care stay and subsequent PTSD symptoms, randomized then into a control group or to this intervention group. Their PTSD symptoms were quantified using a post-traumatic diagnostic scale for DSM-5, which is shortened to PSD-5 questionnaire, scored from 0 to 80, with higher scores meaning more severe symptoms, and that was done at baseline, 6 and 12 months. Importantly, the minimum clinically important difference is considered 6. And that's important because in this study they found that there was an improvement in the PTSD scores if you undertook the intervention compared with control, but only by 4.7 points. So it failed to meet that minimum clinically important difference thresholds. Nevertheless, the authors concluded that in patients with symptoms of PTSD after critical illness, a brief narrative exposure intervention was feasible and showed a reduction of symptoms which was less than the predefined minimally clinically important difference, and this effect was found to be sustained at 12 months of follow-up. They're surprisingly upbeat given that sentence that I've just read out, which sounds a lot like it didn't really make any difference. But they did note that some secondary outcomes they looked at demonstrated positive improvements. So particularly depression levels, health-related quality of life, and overall disability. But I don't know about you. I think given the amount of time it takes to deliver this intervention, it's difficult to see, firstly, how this would translate successfully into UK general practice unless there was some specific funding to allow it. It feels like one of those things that feels like a good thing to do, but ultimately, even though the authors suggest the findings support the further evaluation of this intervention in general practice, they always say that, don't they? It doesn't really feel like it's going to be something that can justify the time and the effort given the level of outcomes that it provides. For me, however, perhaps the really important learning point here is the level of enduring mental damage that surviving a critical illness can leave on a patient. Even if it's unlikely that a GP-led intervention is going to be the solution for this, given the high prevalence after a serious illness, it does highlight the need to proactively ask patients about this. And I also think that what that book showed me is that the numbers of people that have experienced significant trauma events in their lives is probably much higher than we would anticipate. And so if you are seeing people with mental illnesses, particularly if they're presenting with PTSD symptoms, then I think just gently exploring whether someone may have suffered trauma would be really, really valuable. And in doing so might open up a whole new world of understanding that we've previously had closed to us. Okay, on to our second paper. And this is from the Lancet last week. And I feel like I haven't done a piece of research on the GLP1 receptor agonist for a while, so it's about time. This paper is about semaglutide and peripheral vascular disease. Yes, it's another potential indication for these drugs. This isn't one I've seen explored before, so potentially it's quite interesting. In fact, I haven't seen any research on peripheral vascular disease for absolutely ages, but of course this is a problem that has not gone away. I feel like perhaps the rates of peripheral vascular disease and the need for interventions like revascularization has fallen in recent years. As we've had a reduction in smoking, then we've had this corresponding fall in levels of cardiovascular disease and peripheral vascular disease. But now we have another big driver, and that's type 2 diabetes. And that's definitely on the rise, of course, particularly as we're seeing growing rates of obesity, even at younger ages, driving ever earlier diagnosis of type 2 diabetes. It's very conceivable then that we might actually start seeing an increased rate of peripheral vascular disease in much younger people. Given that it seems the trajectory is for many more of our population to be using these incretin-based weight loss medications, it seems pretty reasonable to explore whether they may be of benefit in treating peripheral vascular disease. Now, I should point out that this study is paid for by the manufacturers of semaglutide. Don't worry, they're not paying the podcast, but I guess it isn't a surprise that they're funding this research because, as with any new medication, exploring any new indication, the research is typically funded by the drug manufacturer. But let's just keep that in mind as we explore the interpretations of the findings of this paper. So this was a double-blind, placebo-controlled, randomized trial conducted in North America, Asia, and Europe in patients aged 18 and over who had type 2 diabetes and peripheral arterial disease with intermittent claudication. They were randomized to either have subcutaneous semaglutide up to 1 milligram per week dose or placebo injections, and they had either of those for a year. The primary outcome was comparing maximum walking distance pre and post intervention, which they did on a treadmill so that it was standardized and easily measurable. Just to give you an idea about the study participants, 75% were male, the median age was 68, 2/3 were white, 1/3 were Asian, a tiny minority were black or African American. On average, they'd had diabetes for 12 years and a body weight of 81 with a median BMI of 28. That BMI is worth noting just because it's substantially lower than the BMI of many participants in recent GLP1 trials. But of course, this is looking at a population who has type 2 diabetes and the management of its complications rather than a population specifically necessitating weight loss. To be eligible for inclusion, patients had to be able to walk on the flat for at least 200 meters despite their claudication, but then they were put on a treadmill with a fixed speed, which was 2 miles an hour, and a fixed inclination of 12%, which is pretty steep and obviously much more challenging than walking on a flat. And then they used that treadmill test as the measurement for the maximum walking distance. Just to give you an idea, the median before they did any interventions for that maximum walking distance was 185 meters. The results showed that both groups improved their maximum walking distance, but it was much better in the semaglutide group. They had a median improvement of 21% compared with 8% in the placebo group. That was a statistically significant difference. I think you could debate how much of a clinically important difference it is. So the actual absolute difference in pain-free walking distance was just 14 meters between the two groups. That's the median, and the mean absolute improvement was 30 meters. Neither of those sound life-changing. I think at this point it's worth just thinking about why they think that GLP1 receptor agonists may be useful in the context of peripheral vascular disease. Inflammation is associated with peripheral vascular disease. It can drive worse outcomes as well. And of course, the GLP1 receptor agonists are meant to have anti-inflammatory as well as positive metabolic effects. Having said all that, As the authors acknowledge, it may well be that the improvements they're seeing are simply down to the weight loss that's induced by these therapies. They showed that in the treatment group, but also the placebo group, the greater the degree of weight loss, that was associated with a greater improvement in peripheral vascular disease. If you're carrying less fat around, then your blood can be used in the places where it's really needed. And of course, if you've got less weight, particularly when you're walking up a hill, the amount of work that your body has to do, and particularly your lower legs, is significantly less, so you need lower blood flow. The authors conclude that semaglutide significantly improves functional symptoms and health-related quality of life in people with claudication due to peripheral arterial disease with type 2 diabetes. They suggest that semaglutide should be prioritized amongst treatments for this population. I think I'd be more inclined to agree with that last statement if it wasn't so expensive. If this was a £2 a month medication, or maybe even a £20 a month medication that gave a bit of improvement or potential improvement to people with PAD, PVD, however you want to say it, who were struggling with their walking distance, that would sound quite reasonable. But the problem is, of course, at £200 a month, the health economics start to look a little bit more sketchy. The paper even suggests that the degree of benefit in semaglutide for peripheral vascular disease is similar to that seen with nafatidrafural, if I've said that right, which has a NHS tariff price of around £9 per month, considerably cheaper. The authors rather sportingly suggest that semaglutide now needs to be looked at in patients with peripheral vascular disease and no diabetes. But it seems to me that we've already got established, moderately effective, but much, much cheaper interventions that could be done for that group. In the context of someone who does have type 2 diabetes, I think it's a stronger argument because here I think the GLP1 receptor agonists are still underused in the UK and are associated with other benefits, including, of course, improvements in cardiovascular outcomes as well as diabetes markers. And it is true, I suppose, that patients with peripheral vascular disease are at higher risk of those cardiac complications. So actually, maybe this does promote the GLP-1 receptor agonists as a potential option after metformin and after an SGLT2 inhibitor. The debate around where GLP-1s should fit into type 2 diabetes management continues. And really the barrier, of course, is cost. I dare say if any of these manufacturers could make it much cheaper, then actually we'd see much wider uptake. Could they make it cheaper? Or do they just not want to? I'll let you decide. Now, finally, we're going to have a look at the BJGP. And this month's issue of the BJGP is all about cancer. It's another fantastic edition, well worth a read. On the podcast last time, we've already explored one of the papers that published in this month's BJGP. So that was looking at the rates of chest x-ray use in practices and the outcomes for lung cancer with staging and survival. So we interviewed the lead author, Stephen Bradley. If you didn't check that out yet, go back to the last podcast and have a listen. And there's a broad scope to the research that they've published this month. There's a paper looking at practice-based clinical decision support tools to help with cancer diagnosis, which showed it actually didn't improve the rates of patients receiving guideline concordant care. A pat on the back for Australian GPs who are clearly already doing a good job by the looks of things. There's a paper on the use of artificial intelligence to identify key clinical features from patient notes to help improve early diagnosis of lung cancer, which has positive findings for the area under the curve, whatever that means. But apparently it can improve diagnosis by around 4 months in a significant majority of lung cancer patients. Who knows where the world of AI will take us, but we've already had electronic tools integrated into our computer systems flagging up patients who were at higher risk of cancer and may merit referral, and we largely just ignored it. So I wonder if AI will be any better at overcoming the human element here. But we're going to have a look at a paper on something much more simple than new digital technologies. We're going to have a think about an intervention to improve physical exercise in cancer survivors delivered by real people. So the title of the paper is Patient Outcomes from a Physical Activity Program for Cancer Survivors in General Practice, an Intervention Implementation Study. This is actually from the Netherlands, performed in Dutch general practice, which is typically considered fairly similar to UK general practice. It's also not a randomized controlled trial. It just had a single arm where everyone had this same physical activity intervention. It comprised of a number of counselling sessions with a primary care practitioner whose aim was to increase daily physical activity in the participants, and sounds a little bit like what many of us now have access to through our PCNs. I used to be a really big advocate of the idea about having a health coach within our practices as a mechanism to try and improve engagement with lifestyle modifications. And then we all got PCNs and this became a reality. And over time, I became less convinced that it seemed to be making a big difference. But this paper actually shows that using this simple approach, not only does it improve physical activity in patients who have had cancer, but can also improve a wide variety of other symptoms. To be clear, this research is not looking at cancer recurrence or survival, prognostic outcomes. Although that research is already well established, physical exercise has been shown to improve cancer outcomes, reduce metastases, improve survival. And if you're interested in having a look at that data, I'll put a link to a fantastic website called Moving Medicine, which, if you're not familiar with it, it's partly an online guide to how clinicians can quickly discuss the benefits of physical activity within a consultation and hopefully motivate change in patients. But also it's got a really great evidence-based resource within it, putting together loads of research on the benefits of exercise, not just for cancer, but a wide range of conditions. Anyway, coming back to our paper and thinking beyond simply pure survival, if you're a cancer survivor, you're more likely to have a wide range of negative symptoms than the general population. So 40% are reported to suffer from fatigue. Anxiety is very common, with 21% reporting that. Depression is more common as well. All of these impact quality of life. Now, the data is very positive about the concept of physical activity helping with these type of symptoms, potentially more so even than psychological or drug therapies, particularly in the sphere of fatigue. So they recruited patients who were 18 and over who had had cancer and completed their treatment at least 6 months prior to entering the study. And the primary outcomes they were examining were measurements of self-reported symptoms, including fatigue, depression, and anxiety. And then they also looked at some secondary outcomes, including things like step count, calorie expenditure, weight, physical function, self-reported quality of life, and levels of physical activity. They were followed up over 9 months with a baseline questionnaire and then further assessments at 3, 6, and 9 months. They invited over 500 patients and just over a quarter opted to participate. So I guess you could say that most people weren't that interested. But those who were interested showed great engagement with the program and some really positive outcomes. So there was improvements in all the primary outcomes and most of the secondary outcomes as well, with improvements in fatigue levels, mental health, step count, weight, and caloric expenditure too. Patients were given an activity tracker, and about half of them thought that that was really very useful in achieving their goals. 2/3 of participants would highly recommend the program to others, and 1/3 would recommend it to some extent. 11 patients dropped out before even the start of the study, and about a quarter dropped out during the program, but perhaps that isn't a surprise with this type of intervention. It still means that of the patients who were interested, a significant proportion of them did successfully complete the program. One of the really interesting findings was who wanted to participate. So contrary to what you might imagine, patients were more likely to have less formal education, higher unemployment, undertake less physical activity normally, and have worse symptoms of fatigue and mental health than non-participants. I think there's an inclination when we think about lifestyle medicine and lifestyle interventions, and this is something that's going to be debunked on our new lifestyle medicine course. So remember, check it out. That's coming up on the 6th of June as a half-day online webinar. But I think there's this inclination to think that people from more deprived backgrounds, maybe people from ethnic minorities as well, are less interested in engaging with lifestyle interventions. But this study shows that that's absolutely not the case. They are interested. They do want to participate given the chance. And of course, because deprivation is associated with worse outcomes for a whole range of conditions, this is the group that are likely to gain the most from participating. The authors conclude the current study shows that home-based physical activity programs with primary care professional counselling and activity trackers can reach long-term cancer survivors with poorer health status and shows favourable health changes, particularly on physical activity and physical function. Such programs may benefit the health of a rising number of cancer survivors visiting primary care. And if you've been on our cancer course over the last few years, you'll know that that's great news, that there are ever more cancer survivors, but you'll also appreciate that more and more primary care is the place where we're going to be managing their long-term care. Okay, that's it for the research today. And on that note, I hope that if you're not listening to this whilst you're out walking the dog or going for a run, then you can get out and enjoy the beautiful weather that we've had over the last few weeks and hopefully will continue for a little bit longer. I hope that that last paper will inspire you to enjoy the great outdoors a little bit. Don't forget to check out the nbmedical.com website for everything that's coming up in the near future. You can always get in touch with us on hot topics at nbmedical.com. We're also on Facebook and Twitter, or X as it's now called, and apparently we're even on YouTube now too, if that's your thing. There's something out there for everyone. I'll be back in 4 weeks. Until then, take care. Bye-bye.